Hello, this is Aaron Shoemaker, and I'm here today with Mark Beauchamp. He is the head of infectious disease at 86th Street, and we're going to talk today about fluoroquinolones. There's been a recent black box update on fluoroquinolones, and because of that, I wanted to get some information for all of our providers across the medical group on that subject. So, Mark, what's the update on fluoroquinolones?
Well, as you know, fluoroquinolones are very heavily used, and because of that, there's a lot of exposure to them across the country and around the world. And as we get feedback from surveillance, we find things that we may not have thought were important initially, but then the FDA reminds us that they are. And most recently, there's been a lot of press as well as edicts about the actual impact of fluoroquinolones on tendons, arthropathies, and arthritis. And that ultimately resulted in the FDA giving us a warning that the use of fluoroquinolones in certain populations should maybe not be contraindicated, but you should be very aware of when you're actually using these drugs in these populations. These populations specifically include people over the age of 60, as well as people on steroids chronically, as well as people that have myasthenia gravis. The data that led to the FDA statement was out of a study from 2012, which looked at about 30,000 patients, indicating pretty wide catch of all comers, and it ultimately showed that there was a very high risk for tendinitis and tendon rupture, and that actually occurred in about 6% of people, so very high number. And so as a result, when using these drugs, we have to be very cautious in certain populations. I think we're going to talk a little bit about the top 3 places we use these drugs. And the first I think we'll mention is respiratory infections. Fluoroquinolones tend to be used a lot in this scenario. Certainly they're indicated for community-acquired pneumonias and have great coverage for everything, including Legionella. I think that first of all, you have to convince yourself that the patient has a bacterial infection and that they need an antibiotic. If they were young, have few problems, are not over the age of 60, not on steroids, absolutely consider a fluoroquinolone such as Levaquin or maybe Avalox. However, if you have a population that you think is at risk, other options that are very, very good options include something like Ceftin or doxycycline. Both of those are well tolerated and have maybe not that many less side effects, but certainly less severe ones like we're talking about today.
Great.
Urinary tract infections are another place where fluoroquinolones are heavily used, specifically ciprofloxacin. And again, in the population we're talking about, the elderly, this is a major, major reason to see your primary care physician. Again, there's no reason that you can't use a fluoroquinolone, but be aware that in greater than 60-year-olds on steroids or people who have myasthenia gravis, you probably should at least consider an alternative. And in those cases, we still default back to the old school drugs, which include Bactrim, Keflex, cefuroxime. All of these are very good. And in terms of antimicrobial stewardship, in the community, they're still fairly effective. Now, if you have an extended care facility patient or something, you're looking at some resistance and you should be cognizant of that, and maybe in those scenarios a Cipro prescription may be more warranted, but again, that's individualized.
What would be your first choices for diverticulitis or cellulitis if we're trying to avoid fluoroquinolones?
Great. I think diverticulitis as an outpatient entity, of course, are the milder cases. So a lot of people will default to Cipro and Flagyl. It's a great combination, okay? Just again, remember which population you're looking at, and of course diverticulitis is a 60-year-old plus disease often. In those scenarios, we like the use of Augmentin. We like the use of Augmentin, even plus Flagyl sometimes, depending on what you're trying to treat. Cefuroxime plus Flagyl. And again, we're looking at drugs that are fairly inexpensive,
right,
and they're just as effective. So I think that's a very reasonable alternative to somebody who does not need inpatient admission or further workup. In terms of cellulitis, let's not use fluoroquinolones in cellulitis. I think we've got other options. Doxycycline is an exceptional drug. Keflex is still exceptional. Again, if you're worried about MRSA, we wouldn't be talking about fluoroquinolones anyways.
Great, Mark. Thank you.
Absolutely.
We appreciate the update. Wanted to bring you this clinical update that really stems out of that new black box warning, and also remind us about antimicrobial stewardship, and both for resistance and also from the standpoint of cost as we prescribe. So thank you for your time.